Robbie, you will stay muted or I'm going to mute you.
Oh my God, I almost interrupted you, but I missed completely. I'm so sorry.
I said you're going to either stay muted or I'll mute you with my hosting privilege. And I see Robbie and the Baltimore Sinai Hospital there. How are you guys? I miss you. All right. Welcome to another RLR where Robbie is put in the hot seat. And we try, as we see oatmeal on the side of, not oatmeal, I can't even diagnose what's in his mouth. Oh man, that looks delicious. Is that egg yolk on the plate? Oh my God. All right. I am salivating because I haven't had a proper breakfast. And today, actually, you know what? Gabby, why don't you introduce who's the case presenter?
Yeah, sure.
Tiago.
Tiago is with the sound on. So Laura spoke with me this week because she has a very wonderful case that she wants to present. And she's also from Brazil, and she also always participates with us, and she's very excited to present the case.
All right, so Robbie doesn't aspirate on that food. Thank you so much, Gabby. Laura, do you want to unmute yourself? Tell us a little bit about yourself. What do you enjoy doing for fun? And I'm so sorry that Brazil lost in the Copa America. Long live Messi.
Hello, everyone. So my name is Laura. I'm a third year medical student here in Brazil. And I don't know, for fun, I like to be with my cats here. And yeah, so yeah, that's me. I'm really happy to be here. I really appreciate the chance of learning with you all. And yeah.
Thank you so much. And then Maria, if you don't mind, unmute yourself. Tell us what's going on in the world of Maria. And then after that, we'll take over the whiteboard, and Laura, you can get going, and Robbie will tackle the first aliquot.
Hi, friends. My name is Maria. I'm from Guatemala. I'm currently studying for step 1. So yeah, wish me a lot of luck, everybody.
Can I start?
Yes, please. Gabby's going to scribe, Maria's going to teach, and Robbie's going to eat.
Okay, so the chief complaint is jaundice.
Hi, it's so nice to meet you, Laura. What a start. By the way, how many cats do you have?
I have 3 cats and 3 dogs.
3 cats? Oh, holy smokes. That's 6 full-time jobs. Kudos to you, in addition to being a medical student. Cats sounds a lot like carrots, which is the only thing that this could be. Yes, if you eat a lot of carrots, not cats, you might become yellowish. But here we'll pretend that that's not the case. But in real life, the way you would know it's not beta carotinemia, unlike jaundice, is the eyes, specifically the conjunctiva, would not be pigmented. So here, the key question is, what is the molecule that's causing the patient to turn yellow? And in one sense, there's 3 possibilities. There's beta carotinemia, which again comes from carrots, but that won't make the eyes yellow. And then the others are direct and indirect bilirubin. Those lead you to a very different landscape. Direct hyperbilirubinemia leads you to study closely the hepatobiliary tract. Indirect hyperbilirubinemia can also take you to the hepatobiliary tract because Gilbert's is a disease of conjugating the bilirubin. But at least acutely takes you to studying the possibility of hemolysis, delivering more indirect bilirubin to the liver. So if you're trying to be simple about jaundice, you know the patient has turned yellow. It's either carrots, direct bilirubin, or indirect bilirubin. You look in their eyes and they will tell you if they love carrots or not. Direct bilirubin is the liver, indirect is usually hemolysis. But we might be making a key mistake that we reflected on RLR recently. You see how this schema seems like it's mutually exclusive. It seems like it can only be carrots, it can only be the liver, it can only be hemolysis. There are many causes. What if somebody with pancreatic cancer really loves carrots and has a concomitant autoimmune hemolytic anemia? They can have all three causes. So make sure you're not oring in where you might end. I'll say one final thing before I pass the mic to Reza to see if he has anything else to layer on, but I will tell you one key thing. Why do we even begin with the chief concern? Why don't we describe the entire story? It's because if you take the same story narrated over time and you adjust the amplitude of each concern, the diagnosis will change. So if the patient says, I'm jaundiced, fatigued, short of breath, and tired, but they emphasize the jaundice and minimize the shortness of breath, it's very different than if they minimize the jaundice and emphasize the shortness of breath. Those will lead to different diagnoses. So which of those three possibilities is more likely when the patient chooses to open with jaundice? And I would argue that it's much more likely to be a hepatobiliary disease when the patient opens with jaundice, because the symptoms of indirect hyperbilirubinemia from hemolysis are more centered around the reduced cardiac delivery of blood, and the patient usually is much more alarmed by their reduction in exercise tolerance, by their shortness of breath, rather than the accumulation of yellowness in their skin. In stark contrast, liver disease is deadly in many ways, but in part because it tends to be silent. It creeps up on people, and the first thing they may notice is jaundice. So jaundice can be all those three things, but if it is presenting as a chief concern, it prioritizes the silent killer, which is hepatobiliary disease, over the much more obnoxious, loud, and more aggressive diseases of hemolysis. Prof. Rez, anything to add to that before we get more data from the three cats and the three dogs and Laura? All righty.
Okay, so it's a 33-year-old female, and she presents with a history of jaundice for 9 days, progressively worsening. She also noticed pain in the left hypochondrium, dark urine, constipation, fecal echolalia, hyperexia, nausea, and vomiting. She also had fever, 39 degrees Celsius, in the previous 2 days. She was told to have liver disease since childhood, but she doesn't know which one. And she reports several previous hospitalizations due to this disease, presenting jaundice that would last a couple of weeks or a month. Do I continue or stop here? Past medical history. Yes.
Maybe Laura, you can just fill it all the way out to the physical exam.
Okay. So as for the past medical history, epilepsy since childhood, and then medications, she takes phenobarbital daily and Diperon for the abdominal pain. As for family history, her grandmother had similar symptoms. And social history, she lives in a rural area. Health-related behaviors, denies tobacco, alcohol, or illicit drug use, and allergies, none.
That's great, Laura. And to just clarify one thing that you mentioned, did you say she's had something similar in the past?
Yes, she says that since she was a child, she always gets yellow. This is how she described it.
Okay, this is so fascinating. Because there's so much data here, maybe the recurrent nature of this illness and the grandmother having something similar, I'll pass on to Robbie to tackle, and then I'll try to localize where the lesion is based on the HPI, based on Robbie's initial schema. So when you are tackling jaundice and hyperbilirubinemia, what is the definitive way to know if this is direct or indirect? Is to do lab tests. But I just made a mistake there. I said indirect or direct. No, this is probably going to be a combination of two, meaning that oftentimes you'll have a component of direct, a component of indirect, and then you have to determine which one is more prominent to prioritize whether this is some form of, hemolysis or some form of intrahepatic or extrahepatic obstruction. There's no way to definitively localize that based on the history. There's no way, zero. It's the labs and then imaging that will help you be definitive on if there's intrahepatic or extrahepatic cholestasis plus minus indirect hyperbilirubinemia. But there's certain clues that will help us here. The fact that the urine is dark in the context of jaundice tells us that it must be direct hyperbilirubinemia. There's always nuances in medicine. You can have intravascular hemolysis leading to indirect hyperbilirubinemia and a dark urine, but not because of the bilirubin, but rather because of the hemoglobin. Not the bilirubin, the hemoglobin. Because this has to just do with the water insoluble nature of indirect bilirubin. So the fact that the urine is dark tells me that there's probably some direct bilirubin, unless there's concomitant intravascular hemolysis, or whether the patient is dehydrated or hypovolemic with a dark urine. But then there's another clue that even further supports the hypothesis that there's going to be a direct component to the hyperbilirubinemia, and that's the pale stools. So how can you get pale stools? You won't get pale stools from hemolysis, Gilbert's, or the various causes of indirect hyperbilirubinemia. You'll get pale stools if there's something obstructing the secretion of bilirubin into the GI tract, where it can then be metabolized by bacteria that gives stool the dark color. So the pale stools, the dark urine, together, it tells us that there's direct hyperbilirubinemia, and tells us that we have to be very cautious about extrahepatic obstruction here. Something disrupting the flow of bile into the GI tract. But there's something else that's super important here. That's the temperature, 39 degrees Celsius. If you ask the question, what are life-threatening causes of jaundice? This includes, one of them is cholangitis. So fever, jaundice, pale stools, cholangitis rises to the top of the differential diagnosis. So I'm going to pause there because I think the other component of the history is so fascinating, because easily you could say, well, how about if this patient had a stone, caused obstruction, led to cholangitis, and now but that wouldn't explain this recurrent nature. So I'm really interested to see how Robbie analyzes that component of the history.
That was beautiful. Such a great way of making a compelling argument that at least like part of the disease process is in the right upper quadrant. And I love that caveat. Like, you know that she probably has something in the right upper quadrant, but you're not dismissing a superimposed indirect process. I got to say, it's very hard to make progress and understand recurrent episodes of jaundice without knowing one thing. So all the causes of cirrhosis, or chronic liver disease, ranging from intermittent toxin exposure like alcohol to infections like Hep B and hepatitis C, autoimmune hepatitis, Wilson's, etc., all can have recurrent episodes of decompensation that ultimately lead into cirrhosis. So I think the key question to analyze this thoroughly is to try to make the following conclusions. Is this a recurrent episodic disorder? Or is this a recurrent episodic disorder with secondary progression to cirrhosis? Because it's a much more intriguing hypothesis and a much more restrictive set of conditions if this person just has bouts of jaundice and goes back to normal, versus if she has bouts of jaundice that will ultimately lead to cirrhosis, which I think is possible for any cause of cirrhosis with a few exceptions. So for example, you'll hear that hemochromatosis almost never has an acute component. But the list of diseases causing cirrhosis that don't have intermittent acute components is very narrow. So here we could say she's going to have a cause of cirrhosis that intermittently flared up many times before. If though we say that her grandmother has similar symptoms, it's tempting to come to the conclusion that something shared by genetics may be the cause of this disease process. Things like Wilson's disease, alpha-1 antitrypsin deficiency, and less commonly cystic fibrosis are examples of heritable liver conditions that can cause acute decompensation. But just because two people related to each other have a common syndrome does not mean that it's genetic. For example, it may be a genetic disease with a propensity, like autoimmune hepatitis, that's not genetically heritable, but a propensity for a genetic disease. But more importantly and most prudently, it can be an infection passed on maternally. Could this be hepatitis B intermittent reactivation with the grandmother having hepatitis B, the mother having hepatitis B, and now the daughter having hepatitis B? That's all very possible. So all I'm arming you with is caveats. I think it could sound very appealing when somebody's having recurrent episodes of jaundice to say this is some sort of really fancy schmancy disorder, but it may just be all the causes of cirrhosis that decompensated. It may also be tempting to say, oh, a family member has this disease, so it must be genetic. Infections go through family members, toxins transmit through family members, and genetic propensities to diseases go through family members too. So my advice, don't drop your anchor on this being episodic and this being familial. It could be neither of those things. Yeah, that's what I'd say. Don't fall. There is a trap here in the HPI. Don't fall into it. All right, Laura, back to you.
That was brilliant, as always. Okay, so now for the vitals. Temperature, it was 39 degrees. Heart rate, 85. Respiratory rate, 20. Oxygen saturation, 95. Blood pressure, 120/70. Yes, 70. And general exam, she was hydrated, jaundiced, and she had asthenia. And for the abdominal exam, it was soft, symmetric, non-tender, without distension. And it had pain to palpation in the left hypochondrium. As for the neurological exam, she was confused and lethargic. And for the skin, it was jaundice. I don't know if you say this 4 out of 4. Is this how you say it? Yes.
If it's how you say it, my friend, then it's true. But I don't know if it translates globally. Can you tell us what you mean? Like, is it extensive, John? Like everywhere, or?
Yeah, it was like everywhere and intense, pronounced. The eyes were also yellow.
So not carrots. Okay, great. Amazing. Wow, this gets juicier and juicier. You know, I pass on the intriguing aspect of, because I talked so much of the fever and everything else, Teresa, but talk about the pain in the left upper quadrant. Left upper quadrant pain is really intriguing. It's the rarest quadrant to be involved in abdominal pain syndromes, judged only by my experience and not any data review. So that's a big caveat. I see right upper quadrant, right lower quadrant, and left lower quadrant almost every day. But when left lower quadrant pain is present, it usually is very intriguing. The most common localizations we'll talk about at the end. I'll tell you not to be fooled, because left upper quadrant pain can be left flank pain, and it may involve the left kidney. It may also involve the left lower lung or the pleura. But most often it involves the stomach, distal pancreas, or the spleen. Most often the stomach, the distal pancreas, or the spleen. Now, which of those three is most compatible with the jaundice hypothesis? It's the spleen. The spleen is a fascinating organ that Venn diagrams with both direct hyperbilirubinemia, because the liver can result in portal hypertension, making the spleen big. And the spleen that is big usually is not painful, but it can auto-infarct and cause pain. Or the spleen can overlap with indirect hyperbilirubinemia because hemolytic disorders, especially chronic hemolytic disorders, can cause splenomegaly, and the spleen can hurt because it's big or infarcts. So here, the left upper quadrant pain makes me worried that the spleen is involved. And if the spleen is involved, it doesn't definitively push you more towards direct hyperbilirubinemia versus indirect hyperbilirubinemia. But if you analyze the rest of the landscape, there's no evidence of portal hypertension, which would be the simplest mechanism of the liver causing a spleen problem. There's no ascites, there's no caput medusa, there's no lower extremity edema. So here we're dancing between direct and indirect bilirubin, and the spleen being involved without other signs of portal hypertension makes it seem more like a primary splenic disorder rather than one that is occurring because of backup of water from the liver. Now, all this is with many assumptions. The first is that this left upper quadrant pain represents the spleen, which we don't know for sure. And the second is that signs of portal hypertension are absent, meaning portal hypertension is absent, which is not true. In fact, Reza just presented a case on Patreon where a patient ultimately had portal hypertension, but had no visible signs of it until we did a more definitive test. So it's intriguing.
And don't you dare blame the examiner on that.
Speaking of the examiner, I'll pass the mic to him to reflect on everything else.
No, I absolutely love that, to have like a schema for left upper quadrant pain and then to prioritize which organ you think is being involved is so eloquent. And what I'll say is, with this temperature of 39, we are most concerned for an infectious process. It's acute onset. The patient is jaundice. So we have to empirically start antimicrobials. Which agents do we start? We want to target gram-negative and anaerobic organisms. So in this patient, ertapenem would be a very reasonable choice. Or if you wanted to do a third-generation cephalosporin plus an antimicrobial against GI anaerobes like flagyl, so ceftriaxone and flagyl would also be appropriate. And then the last comment I'll make here is just like piggybacking off of Robbie. I think this patient is infected, and I think this infection has triggered some form of genetic predisposition to a disease process. And when I heard Robbie speak, one possibility is hemolysis, which becomes really difficult. So when we look at the bilirubin, we're going to look for the height of the indirect. With hemolysis, you don't get north of 6. But if there's a concomitant obstructive process, then you can get north of 6. But Robbie, do you remember the one case we discussed with hereditary spherocytosis? And I think there you taught me like how hemolysis can lead to right upper quadrant pain through gallstone, pigmented stones. I don't recall where we discussed that case, but that's all I have to add here is just think about the management, antibiotics, fluids, and then thinking about some kind of hemolytic disorder that's triggered by whatever revs up the immune system, here being likely an infection.
Okay, so me again. White blood cells, 7,400. Hemoglobin 9.9. And platelets 250,000. Sodium 142. Potassium 3.3. Blood urea nitrogen 16.8. Creatinine 0.51. AST 27. ALT 26. Alkaline phosphatase 133. Total bilirubin 20.54. And direct bilirubin 9.16. And indirect 11.38. Albumin 2.7, CRP 171, 384, sorry, thousand. Yes. What else? LDH 407, ESR 127, PT 13.5, PTT 25.6, reticulocyte count 0.5, and direct Coombs negative. Should I talk about the urine already? Yes. So bacterioscopy negative. Urine analysis, it was turbid, it had biopigments and biocytes, and the culture was negative. VDRL negative, and pregnancy test also negative. So the last part is the imaging. Should I talk about the imaging or stop here? Yes?
Yes, please.
Okay. So the CT showed left kidney heterogeneously impregnating with contrast, suggesting pyelonephritis with renal abscesses, liver with slightly enlarged dimensions, regular contours, and attenuation coefficient within normal limits, and cholangiography showed normal intrahepatic and extrahepatic bile ducts, and the biopsy showed liver histology demonstrating central lobular cholestasis.
Thank you so much for all that information, Laura. And I'll explain why I wanted the imaging before initiating the discussion. You know, I think that honestly, I love hearing Robbie break down bilirubin, and he will do this more justice than I can. So I'm going to leave the bilirubin discussion for Robbie, because I think it's very nuanced, looking at the degree of hyperbilirubinemia, looking at how it's fractionated. And so I can't wait to hear the mathematician break that down. What I'll focus on is I'll talk a little bit about the LDH and the CT scan, and then give the rest to Robbie. So the CT scan is very important. You may say, wait a second, bilateral pyelonephritis? How is that possible? Well, it is possible, and it's not that uncommon. You can see this in many patients. Just because someone doesn't report, CVA tenderness on both sides doesn't mean they don't have bilateral pyelo. So we know we're dealing with the urinary tract infection, but we have to specify what we mean by that. We're not talking about urethritis. We're not talking about cystitis. What we're talking about is an ascending urinary tract infection, pyelonephritis, that is now complicated with renal abscesses. So this explains why this patient is so inflamed. And this is what you often see in the context of pyelo. These patients look sick. And even when you start antibiotic therapy, you don't expect an immediate response. The question becomes, why does she have such severe pyelonephritis? You probably all have seen patients with pyelo and urinary tract infections. A quick pearl, a simple UTI shouldn't lead to fever. Once you have fever and you're worried about a urinary tract infection, be worried about some complicated form of a urinary tract infection. So how do you get pyelonephritis? The simplest explanation is that you have something that's downstream, and then the bacteria ascend upwards, involving the renal parenchyma. Other ways you can get pyelo is if you have some form of hematogenous infection that then spreads to the kidneys. This is far less common. So when I look at the CT scan, I'm like, okay, I know the acute inflammation, but I haven't solved the case just yet, because now I have to explain, why is this patient so hyperbilirubinemic? Why is the patient so jaundice? And then I have to marry these two together and try to identify a single explanation for both phenomenon, though I'm open to the possibilities of multiple processes happening. The reason I want a single explanation is this woman is young. We weren't told of any immunocompromised status in this host. So it's hard to separate this infection of the kidneys that she likely has with the renal abscesses and what's happening in the liver. So let me pass the mic to Robbie. It's a bit nuanced and complicated, but let's dance, my friend.
Oh, dance we shall. I love that. I love that breakdown of pyelo, and I cannot ignore it, you know? Can't ignore it. And I think maybe it's a good time, and I hope we can reflect on it in an episode soon, but maybe it's a good time for another perspective on jaundice. So, oh, wait, hold on. Okay. So, Billy is better than creatinine. That's the takeaway. Bilirubin is better than creatinine. Now, if you're confused, great. Let's unconfuse you. By the way, that should be the goal of all teaching, is to make somebody less confused. So if you start by making them more confused, you will have a tremendously high chance of success in unraveling the said confusion. Why is bilirubin better than the creatinine? It's because you can immediately, by studying the nature of the bilirubin, figure out if it's prehepatic or intra or post-hepatic. Nothing about the creatinine tells you if it's pre-renal, intrarenal, or post-renal. But if you study if it's indirect or direct bilirubin, you can make the conclusion if it's prehepatic when it's indirect bilirubin, and it's intra or post-hepatic when it's direct bilirubin. Fair? This approach is flawed sometimes. We like this elegant approach to say, oh, if it's indirect, it's probably Gerbera hemolysis, it's direct, it's probably in the liver, or if it's probably post-hepatic. But that fails. That fails when you have both. So what do you use? How do you make progress? Well, we can use everything else we have here. We took a picture of this area and saw it was totally fine. We biopsied this area and saw there was accumulation of pigment there. Indirect hyperbilirubinemia and an anemia and LDL elevation is a pretty good case for hemolysis. But that's what I think the law of proportionality should apply. You're telling me that indirect bilirubin of 10 is coming from destruction of 4 or 5 red blood cell units? This person has a hemoglobin of 9. Presumably, she has a hemoglobin of 13 or 14 at best, baseline. So 4 units of red blood cells being destroyed is causing an indirect bilirubin of 10. I don't believe it. Don't believe it. Could it be contributing? Sure, but it's not the only thing. It's not the only thing. Where does the pyelo fit in? Well, we know there's a problem here. How can the pyelo fit in? This is called intrahepatic cholestasis. And how can the pyelo fit in? You'll have to wait until I load it. One sec. Okay. Intrahepatic cholestasis results from many things. The most common is drugs, antibiotics, over-the-counter things. The most intriguing are autoimmune diseases like primary biliary cholangitis, which can be familial. But we're in the world of infection, right? How can you get intrahepatic cholestasis from infection? Well, you can get esoteric infections like leptospirosis, or very rare versions of viral hepatitis. But look at this. There is a fascinating hepatic to biliary connection where for some reason patients with pyelonephritis stop excreting their bilirubin. They get stunning of their bilirubin. No different than the stunning that sepsis caused, the intrahepatic cholestasis of sepsis. Pyelonephritis is very well described to cause a stunning of bilirubin. Now, usually, to be honest, it's actually mostly just an alk phos elevation. But here it's hard to ignore that possibility. So where am I at, honestly? I think this patient does not necessarily have to have one diagnosis. I think if we're pre-hepatic, intrahepatic, post-hepatic, a post-hepatic disease is probably excluded based on the imaging. And intrahepatic disease is nearly confirmed because you biopsied and saw cholestasis. And what that intrahepatic cholestatic disease is, in the context of pyelo, it's hard not to speculate whether pyelo is causing intrahepatic cholestasis. And you have to wonder, hey, is this patient have an underlying hemolytic disorder that's contributing to it? So is it pyelo plus intrahepatic cholestasis, or is it pyelo plus G6PD deficiency causing both indirect and direct bilirubin? But I think what you can take away from this case is you can almost definitively exclude extrahepatic cholestasis, with imaging, and the rest is analysis of the case, of the entire other dimensions of the case. Patients with kidney disease can get liver issues by an unknown phenomenon, no different than when patients get septic, they get intrahepatic cholestasis. But that leaves us at the end of the day was, why is this patient having such horrible kidney disease? And that is a longer reflection, which I'll pause on for now and see if, Rez, you have any reflections, thoughts that occurred to you while I was rambling away, or other ideas before we give Mike.
My friend, I know I joke with you that you ramble, but the same way that the pyelonephritis can stun the intrahepatic bile ducts, your discussion always stuns me. I have nothing to add. And I honestly, I was having difficulty marrying the two together. I wasn't aware of pyelo and intrahepatic cholestasis, and I'm still having difficulty explaining the recurrent nature of this patient's like jaundice. And I agree with, I saw Travis commented on a haptoglobin. I think that would be important because maybe it's like multifactorial with some form of hemolysis plus some stunning of the intrahepatic bile ducts plus pyelo. And then I would make sure she's, like as far as like her sexual practice and the way she cleans her urinary, stuff, what is her risk factor for ascending UTI? I see Gabby has her hand raised. Gabby, what's going on?
No, I just wanted to do a correction because I heard wrongly. She had the CT had an abscess only in the left kidney, so not bilateral. Okay.
That's really helpful because sometimes you do CT scans and you get like, right now I'm taking care of a patient with gallstone pancreatitis and the gallbladder is like thickened and unclear if it's inflamed. So sometimes you get just findings that don't correlate clinically, but here with the abscess, the paranephric standing, the fever, like it's very difficult to dismiss, the likelihood of pyelonephritis.
Okay, amazing as always. I just wanna. Okay, so the final diagnosis. That's all I have now. Can I can I say it already, or you wanna? I don't know. Discuss it more.
Yeah, I think you can say it.
Please save us.
Okay, so the diagnosis is acute pyelonephritis and decompensation of benign recurrent intrahepatic cholestasis.
Robbie, where did you learn that? My gosh, you said it's a well-known association. Well, not well-known to me.
I don't know if I don't know where I learned it, quite honestly, but that's, by the way, that's the cool part of just having an electronic record. You can always look up your external brain in real time in front of everybody. But did
you see how cool he was and nonchalant? He's like, yes, it's very well-known association. I was like, well-known to who?
It's well-known to Nar, who's now very perturbed by my giggling. He hates it when I giggle at high frequency, which is what you're doing to me. Laura, maybe you can teach us this. Honestly, like I've read maybe one or two things about this, but what did you learn about this? And maybe after you teach us, we can. I see that there's some questions coming in the chat, so we can reflect on them. But yeah, teach us what you know, please.
Yeah, so I'm gonna read it to you just a little bit. So benign recurrent intrahepatic cholestasis is a rare autosomal recessive disorder characterized by repeated episodes of intense pruritus, which she didn't have, and jaundice. And each attack can last from several weeks to months before resolving spontaneously. So it could be like completely asymptomatic for months or years, and then have the symptomatic periods. So yeah, it does not lead to progressive liver disease, but it seems to be associated with a viral prodrome and inciting viral agent or toxin. So yeah. Wait again, go back. Oh my God, I lost you.
No,
No, you have us.
Oh, here. Okay.
I've never heard of this before. This specific syndrome. I can't wait to read more about it. And I think it's fascinating that the bilirubin can be such a distraction. You know, like this patient has a genetic condition that whenever it seems that whenever something else goes wrong in her body, she accumulates bilirubin. And what a distractor. Can you imagine that? Like if you like have a cold, you become jaundiced. If you stub your toe, you become jaundiced. Like that's so.
Robbie, I love how you at the
Yes.
beginning you started saying we should focus on what the patient's chief concern is. I wish here we didn't focus on the jaundice. That led us astray.
But now you know, like now you know, when the reason people talk about beta carotenemia all the time is because it's a distraction, right? Like somebody's coming in for something, they're coming to you, and you don't focus on their carrot skin, focus on why they came in. And this is another great example. So I think our schema for jaundice should be carrots, benign recurrent intrahepatic cholestasis, direct hyperbilirubinemia, indirect hyperbilirubinemia. I see that there are questions in the chat. I don't know if Rez, you saw them, or we can punt
Yeah,
them.
Gabby asked a really great question because Laura, just to confirm, do we still have Laura? I don't see you.
I'm here.
Oh,
Yeah.
great. Was the urine? Thank you. Was the urine culture negative in this patient?
It was.
And so, did the patient get antibiotics before the culture specimen was collected?
Oh, I don't know if
Yeah.
it was before or after. I'm not sure.
So generally, you're right, Gabby, that should raise concerns. Sometimes you might not even have pyuria because you have bilateral obstruction of the ureters with stones, leading to the risk of ascending infection because of stasis. But usually when I see culture negative, like endocarditis, whatever, it's usually because antibiotics were administered prior to collection of the sample, would be one hypothesis. I don't know, Robbie, anything else to add there before we move on to Maria?
Oh, I love it. I completely agree. All right, Maria, take us home, please.
Wow, this was really exciting, and I did my best to capture all of the magic that you shared with us. I really like the point you made at the beginning of why do we start where we start, like why do we start at the CC? And I think it's very important that chief concerns usually tell you what's the symptom with the most gravitational pull, and stories that are similar that focus on different CCs will lead to different diagnoses. So it's a good start. It might not lead to the final diagnosis, but you need to start somewhere. So I think I really like that idea. And then we had the CC being jaundice, and we know there's only 3 things that can cause jaundice: carrots, indirect bilirubin, and direct bilirubin. And I think if you're Latino, mal de amores. You know, there's this play around indirect bilirubin and direct bilirubin, and you always have to figure out which one is the predominant or which one is causing the disease if we have ruled out carrots. So because it's usually they're usually both going to be increased, and you need to prioritize which increase is most significant. You can try to help yourself with key findings that might prioritize direct bilirubin, such as dark urine and pale stools. But at the end of the day, you have to use like all of the tools in your toolbox. So you can't really make a diagnosis out of labs. You have to rely on images. And there's this law of proportionality that Robbie pointed out that I think it's brilliant. Even if you have anemia and indirect bilirubinemia, that doesn't mean the final diagnosis is going to be hemolytic anemia. If you can't explain all the symptoms and all the lab abnormalities with the hemoglobin level you have, it might contribute to a lot of different processes going on, but it might not explain it completely. With jaundice, you definitely don't want to miss life-threatening causes. So cholangitis is something that you have to really be looking to, especially if there's fever, like in this case, always target gram-negatives and anaerobes. And in this case, we had spleen involvement, which is always very interesting. The spleen is a very fascinating organ. And with how it Venn diagrams with jaundice, it Venn diagrams like completely. It can be like a complete circle if you wanted to, because it can be involved with direct bilirubin through liver disease and portal hypertension. And if you're thinking about that, look for other clues of cirrhosis and portal hypertension, but it can also be involved with indirect bilirubin increases through hemolysis, and it might or not be painful, depending if it has like correct vasculature or if it's inverted. And then we had also a UTI. With UTIs, it's also very important to like give them a name and a last name. It's not don't settle with saying UTI. You have to go a step further, try to localize it and try to define the severity. So it's complicated if it's upper tract, such as in PLO or fever. And in PLO, there's different routes for infection. So the ascending infection is much more common than the hematogenous spread, but you have to be open to the possibility of different routes of infection. And we got to the point that we thought, like, should we approach the liver and the kidney separately, or or try to Venn diagram it? And I think what Reza said was brilliant. Try to find like a unifying diagnosis, especially if the person is young and they don't have a lot of extensive past medical history and meds that can cause like many diseases. If they don't have any of that, try to like look for a unifying disorder. And then Robbie just, you're correct, Reza, he just completely stunned us with his liver and kidney Venn diagram about intrahepatic cholestasis that can be caused by drugs, autoimmune disorders, infections, and in infections, don't miss out the possibility of PLO or sepsis, stunning the biliary excretion, which was this case, and I'll hopefully never forget because it was so memorable. Thank you, everybody, for everything.
And Maria, if I can just say one last thing. Your unique ability to teach so eloquently, but then the energy you bring with that is a marker of an amazing teacher. Thank you for that. I really enjoyed that.
I want to say something too. I just want to thank everyone for the great discussion, and I just want to say how much I appreciate the chance of being here with you and learning from all of you. And I want to say that it's not only a safe place to be, but it's also fun. I always have so much fun when I'm watching, or now that I'm actually talking. Yeah, it was great. Thank you so much.
The pleasure is all ours, my friend. It really is a delight to have you. And maybe next time I can introduce you to my only one dog, who can get to know your family of pets. All right, y'all. Have a great Friday, and hopefully we'll see you very soon.